Today, I'd like to invite you all to the CME program on Diagnostic Tools of Pathology by Department of Pathology. Will be presented by Dr. Mahbub, Assistant Professor, Current Charge, Department of Pathology, Bashundhara Ad-din Medical College. And today's program, our Honorable Chairperson is Professor Brigadier General Retired Dr. Muhammad Ali Sir, Principal and Head of the Department of Community Medicine. And our Honorable Co-Chairperson is Professor Dr. A.B.M. Omar Farooq Sir, Vice Principal and Head of the Department of Anatomy. And our special guest, Professor Dr. Muhammad Nur Alam Sir, Project Director and Ex-Principal, Bashundhara Ad-din Medical College. Now, I would like to ask for permission from our honored chairperson, Professor Brigadier General Retired Dr. Muhammad Ali Sir, to start our presentation.
Respected teachers, colleagues, and beloved students, I am Dr. A.B.M. Alam, Professor Current Charge, Department of Pathology of Bashundhara Ad-din Medical College. First, I would like to express my gratitude to our Honorable Principal Sir for giving me the opportunity to present, and my head of the department, Professor Hasnabad Madam, for her valuable guidance and opinion. Now, today's topic is tools of diagnostic pathology. As we know, pathology literally means the study of disease, and there are four cores of this study. Number one is the causation or etiology. Number two is the pathogenesis. Three is the morphologic changes, and finally the clinical manifestations. By morphologic changes, we mean the deviation of the cell and tissue from its normal counterpart, which is specific for diseases and plays the role in diagnostic pathology. Traditionally, the morphology used to be the only gold standard for any diagnosis of disease, but in modern times there are other modalities such as protein expression and genetic analysis. For example, like breast carcinoma, the tumor may look similar on histology only, but if we do molecular analysis, they have vastly different prognostic and therapeutic implications. So these are some of the branches of diagnostic pathology. First one is histopathology, where we study the tissue that are biopsied from body, and the cytopathology, where we study the cells that has been aspirated from a patient. Then there is immunohistochemistry, where we analyze the antigens in a tissue. Then there is molecular pathology, where we detect the genetic abnormalities underlying the disease. And hematopathology, where we study the diseases of blood, bone marrow, and other lymphoid tissues. And there is clinical pathology. Due to time limitation, in this session, we will discuss about the first four branches today. So first, histopathology. What is histopathology? It means the study of morphology from any biopsied specimen. So the next question is, what is biopsy? Biopsy is any tissue that has been taken from a living person for diagnosis of any disease. Then the tissue is processed in a multi-step way, and we finally get a thin, very thin slices of stained tissue on a slide. There are several types of biopsy, such as open biopsy, core needle biopsy, trephine biopsy, punch biopsy, cone biopsy. So the open biopsy, there are two types. The one is incisional biopsy, the other is excisional biopsy. In case of incisional biopsy, only a small fragment of the lesion is taken out for diagnostic purpose. And in excisional biopsy, the whole lesion surrounding normal tissue is taken out. The purpose of incisional biopsy is to diagnose primary, and it is done when the lesion is very large that cannot be taken out in a single surgery. And the purpose of excisional biopsy, both therapeutic and also diagnostic. As you can see, in excisional biopsy, the whole lesion is taken out. We can do it for staging. That is very important for the prognostic purpose of the patient. Next, there is core needle biopsy. The core needle biopsy is gaining popularity very rapidly among clinicians, because in core needle biopsy, we can cut out a very small part of the tissue, so we can study the morphology. and it can be done on an outdoor basis. The patient don't need to be hospitalized, and the complication is very minimal. So as you can see here, in core needle biopsy, the linear fragments of tissue are taken out, and in a substantial number of core is 5 to 6 for adequate histopathology study. The sites from where we can take core biopsy includes breast, lung, liver, lymph node, any intra-abdominal mass. But for core needle biopsy, we have to be cautious that the patient doesn't have any bleeding disorder or any other morbidity that may cause complications. Then there is punch biopsy. We can see that in punch biopsy, there is a punch needle from which we can take out very small lesions. It is mostly used in oral cavity lesions and also in skin biopsies. Then there is trephine biopsy. As we know, trephine biopsy is done from posterior superior iliac spine, and in this process, the fragment of bone marrow is taken out. The indication of trephine biopsy includes the hematological malignancies or any other disease processes where only bone marrow aspiration is not sufficient, like there may be any fibrosis or there may be any metastatic disease. In those cases, we need to do a trephine biopsy. Then there is cone biopsy of the cervix. In this process, it is called cone because by this process, a conical piece of tissue is taken out from the ecto-endocervical junction. Then there is shave biopsy. It is done usually for superficial skin lesions where with a surgical blade, the skin lesion is taken out. So what to do after we have taken a biopsy? The most important part for a physician after taking a biopsy is to put it in a fixative. And if we do not put it in a fixative, what will happen? It will cause autolysis and decomposition of the disease. So what is fixative? It is a chemical substance which prevents autolysis of the tissues. So by fixative, we can allow the tissue for sectioning and allow for staining. And inadequate fixation results in altered morphology. For example, in this picture, you can see the small intestine which has been well preserved by fixative. The nuclear and architectural detail can be very beautifully studied here. But in this picture, we can see a specimen that was not put in a fixative. So any histological study is quite impossible in this case. So you have put it in a fixative with a container. What to do next? Next, you have to label your specimen. Most importantly, name of the patient, registration numbers and specimen including the site from where you have taken the biopsy and the laterality, whether it is right or left. This is very important. Otherwise, there are chances of mishandling or mislabeling the sample. So with this, you need a, so what are the fixatives we need use in histopathology? The most common is 10% neutral buffer formalin. And we have to put the specimen in fixative for at least 12 to 24 hours. Otherwise, if we put less than this time, it will not be properly fixed. There are other fixatives such as Carnoys, Zenkers, Bowen, and glutaraldehyde. Each has its own specific purpose. So when you have put it in a container, you need to send the sample with a requisition paper. So what information we need in the requisition paper, apart from the patient particulars, name of the physician, name of the specimen, fixative used, the most important informations we need are clinical informations. For how long the patient has the disease, where is the disease. If it is a skin lesion, you need to describe the skin morphology. And then relevant investigations such as whether the patient had any CT scan or MRI or any X-rays done or any biochemical test that is needed. For example, for any brain tumor, CT scan and MRI finding is a must. And also for bone tumors, we need the CT scan or X-ray or MRI reports. And the clinical diagnosis and differentials. This is also important for any skin biopsy because many different skin lesions look similar under the microscopic slide. So if you put your clinical and differential diagnosis, we can do special stains or exclude the disease for the physician. So what are the process that undergoes a tissue while preparing? First, we take sections from the specimen and put it in a cassette. Then the cassettes are placed in an automatic tissue processor where the tissue undergoes overnight many steps. Then the cassettes are taken out from the tissue processor and put it in a paraffin block. So this is what a paraffin block looks like, and the paraffin block is put it in a microtome where very thin, as you can see, paper thin sections are taken, usually the thickness of 4 to 6 microns. And the sections are then put it in a water bath where the sections is taken in the slide. And by this process, we get an unstained slide. Then the unstained slide is stained and we get a stained slide. So the next question is, what are the stains that are used? The most common stain, routine stain that is used in histopathology is hematoxylin and eosin. So this stain gives a nucleus blue or violet color and cytoplasm pink color. So you can see the nucleus, the elongated nucleus are blue and the pale cytoplasm, pale pink cytoplasm. This is an HNA stain. But the HNA stain is not enough. In some instances, we need to do special stains. There are many special stains like periodic acid shift stain, Mason's trichrome, Zeren stain, which is needed to see the Mycobacterium tuberculosis, the Jimshai stain to detect H. pylori, Pearl stain to detect iron hemosiderin, Congo red for amyloid, etc. This is a PAS or periodic acid shift stain. We can see the Candida species, the violet color, hyphae and pseudo hyphae of Candida. Then this is a Mason's trichrome stain. This is a picture of liver cirrhosis. You can see the pink nodules. These are the regenerative nodules of hepatocyte, and the blue color you see here is the fibrosis. These are the collagen fibers. Then next, this is a Jimshai stain of a biopsy taken from gastric antrum. You can see the H. pylori, the carved corkscrew-shaped bacilli. Then there is Pearl's Prussian blue stain for hemosiderin, also done on a liver biopsy. You can see the blue granules here. These are the hemosiderin, which is demonstrated by Pearl's Prussian blue stain. So the next part of histopathology is frozen section. Frozen section is different from routine histopathology is that this renders a rapid microscopic analysis, usually when the patient is undergoing surgery. It is also called intraoperative consultation. The most important part of the sending physician is that do not put any fixative, not formalin, not normal saline while you are sending the tissue for frozen sections. Put it in an airtight container and just send it. No formalin, no normal saline, no fixative. So what are the purpose of frozen section? Frozen section is not done to diagnose a specific disease. We need to decide whether the tissue is benign or malignant. If it is malignant, the surgeon will do more aggressive surgery, and if it is benign, surgeon will stop the surgery right there. Next, we know it is a malignant. We need to do the margin status like oral cavity or skin. The purpose is that the surgeon wants to do minimal invasive surgery for cosmetic purpose, so he wants to do minimal loss of normal tissue. So what he will do, he will take the tumor with very normal skin margin and he will send it, and we will need to comment whether the margin is positive or negative for cancer. If the margin is positive, he will do more wide excision. Other importance is to do sentinel lymph node biopsy, to do immunohistochemistry and immunofluorescence. So the upper hand side is the formalin fixed specimens. You see the steps which takes hours to days. But for frozen section specimens, the duration is rapid, 5 to 20 minutes. So why we don't do frozen section for all the cases? Because as I've said already, with frozen section you cannot do a specific diagnosis. You just can say whether it is benign or it is malignant. Next, cytopathology. Cytopathology is the study of morphology of the individual cell or cell clusters. There are several types of cytopathology. The most common is FNSC, exfoliative cytology, and abrasive cytology. In FNSC, we collect the cells from a mass that is superficial, that is palpable. And in exfoliative cytology, the spontaneously shaded cells are collected from sputum, urine, or CSF. And in abrasive cytology, the cells are scraped from any mucosal or skin surface. FNSC, there are two types, superficial and deep from internal organ. The advantages of FNSC that it is rapid, low cost, there is almost no complication, no hospitalization is required. But the downside is that tissue architecture cannot be assessed, and you cannot comment on invasion, and you cannot differentiate versus an in situ or invasive carcinoma. So in brief, the steps of FNSC. First, you will need to clean the target lesion with an antiseptic. Then you have to fix with your 2 fingers and insert a needle. Then the material is expelled in a slide and a smear is made with another slide. Then this smear is ready and it is put in a fixative. So the next question is, what are the fixative for cytology? The most common is 95% ethyl alcohol, and there are also other fixatives. The important thing to remember is that the smear should be kept in fixative for at least 30 minutes. What are the stains? The most commonly used stain is PEP stain. Others are MGG stain, Diffquick, and HNE stain can also be done on cytology samples. This is what a stained cytology slide looks like. So what are the target organs for superficial FNSC? For superficial FNSC, any palpable organ or lesion can be used. For example, the breast, the thyroid, the lymph node, and the salivary glands. But any superficial organ FNSC can be done. The next is, what are the target for deep or guided FNSC? CT guided FNSC is done from lung, kidney, any vertebral lesion, mediastinal mass, or any abdominal mass. You can see this is a CT scan of a patient with a lung mass, and this is the needle that is being inserted into the lesion. And also USG guided FNSC can be done for lesions such as thyroid, breast, lymph nodes, which are not easily palpable or which are very deep seated. As you can see here, the needle is being inserted into the lesion. The other types of cytology we already mentioned about abrasive and exfoliative cytology. The importance of abrasive cytology is that which is taken from cervix, pap smear, which is very commonly done to screen for cervical carcinoma. Next is immunohistochemistry. The role of immunohistochemistry is categorization of undifferentiated malignant tumors and the determination of site of an origin of metastatic tumor, and also in therapeutic and prognostic significance. Like any patient with a breast cancer, diagnosed breast cancer, undergoes this hormone testing and this HER2/neu testing. If the patient is positive for estrogen and progesterone and HER2/neu, there are specific therapies, and which is these patients have a good prognosis. But those who have negative for all 3 of these markers, those are called triple negative breast cancer, these patients has a more worse prognosis. And in this example here, you will see as a biopsy of a bone marrow. In immunohistochemistry, the important thing is if the lesion is positive for a specific marker, it will be colored brown. For example, here, this is a biopsy of Hodgkin lymphoma, and you know the diagnostic cell is Reed-Sternberg cell. So this Reed-Sternberg cell is positive for CD15, so it is showing a brown color cytoplasm and also membrane. And in this picture, it is an acute promyelocytic leukemia, which is staining positive for myeloperoxidase. Next, very brief about molecular pathology. As I started by saying that morphology is not enough nowadays, we need to do molecular pathology. So these are the cancers like thyroid cancer, breast, ovary, leukemia, lymphoma, brain tumor, all these types of cancer. There is uses for molecular pathology because there are specific mutations responsible for each of the disease. For example, in lung adenocarcinoma, there are mutations for EGFR, ALK, ROS1. In case of breast carcinoma, there is HER2/neu and BRCA1/2 mutation. The importance is that if a patient is positive for BRCA1 or 2 mutation, she has the chance that she has an ovarian malignancy, and her family members may also have this mutation. So they need to do regular checkup and even in some case prophylactic or preventive surgery also. The other important role is that there are specific targeted therapy. For example, if the patient has a non-small cell lung cancer who is positive for EGFR mutation, you can give these types of specific targeted therapy which will work very well for this patient. So these are the importance of molecular pathology. So these are the references. Thank you.
Now I will request our chairperson, Professor Brigadier General Retired Dr. Mohammad Ali sir, to share his valuable opinion with us.
Before starting the thing, then I understand the importance of our pathologists, microbiologists, or radiologists, or other investigation professionals. So then they are interlinked. The consultant cannot give the treatment unless getting the report of the investigation. So we have to know what investigation is prevailing in our country. The molecular biopsy or molecular study. It was unknown to us when we passed in MBBS. They are very popular. Genetic study. It is new or not. So that's good. And I think CME is the learning phase for our teacher as well as students. And I need active participation of our students as well as teachers. That will be real learning for us. Thank you very much for Department of Pathology and arrange this nice presentation, because we have learned many things and how the biopsy is taken in different ways. We should understand now. Otherwise, it was unknown for us. Thank you very much. We will continue this CME in next time as well. Thank you very much.
Now I will request our chairperson, our special guest, Professor Dr. Mohammad sir, to say some valuable opinion.
Bismillahirrahmanirrahim. Honorable chairperson of the session and co-chairperson of the session, my dear colleagues and their students. So the very important subject for the doctors and the students also. I will be very much happy if the female students will be here, because these are very important topics for them. And about the speakers, I want to say it was very well versed and well known and very nicely elaborated. But the thing is that the topics, what he has told, that these are diagnostic tools for pathology. Nowadays, pathology includes many subjects. Pathology includes histopathology. He has said about the histopathological part. Pathology includes the microbiological part and biochemical. If any person gets disease, the histopathological changes takes place, at the same time microbiological case, the microbiological problem also arises in this body. At the same time, biochemical parameters are also being changed in the body. So all together, the pathological diagnostic tools help the physicians and doctors to ascertain the diagnosis. In our country, what is happening? It is said the pathologists are the doctors of doctors, and they are the consultants of the physicians. But in our country, it is not, it is ignored. The physicians think that they are all in all and they are the supreme and for the diagnosis and treatment purpose. But until and unless you do the correct diagnosis, the treatment plan will be changed, treatment plan will be wrong, and that for that the patient may suffer and patient will die also. And this is happening in our country. The diagnosis, sometimes the physicians are making mistakes on doing the wrong diagnosis and giving wrong treatment. So you should not be overconfident. You should be confident, but you should not be overconfident. Overconfidence is very bad, dangerous for medical purpose, for medical subject. So, and at the same time, common sense is nonsense in medical science. We should not use the common sense. We should not be overconfident. If there is any sort of confusion, we should go for other tests to ascertain the diagnosis. We have said two things I want to say, that histopathology, now digital scanning technology has come. At the same time, the technology, they have already said modern technology. And in our time, this modern technology were not present in Bangladesh. It's coming up in Bangladesh. And many centers are going to this. And I think this will help us. At the same time, in histopathology, it is seen in America, in the beyond the specialized center who are doing histopathology, about 5 to 10% they are doing the wrong diagnosis. It's difficult stuff. But they have got modern technology and they have got interaction with different hospitals and different consultants. So they can have the second opinion. And histopathology second opinion is very important for the proper diagnosis. But if you want to do the manually, it is very difficult to do that second opinion. It is very much time consuming. At the same time, the delay in the treatment plan. So now digitization has come, and also their digital imaging they are using nowadays. And this digital imaging they are sending to other centers, and the other second consultant or giving the second opinion within a very short time. So the time is being saved and the patient is getting good treatment and in time treatment. Now, the microbiological aspect. The microbiological aspect, many new technologies has been developed and is in practice in Bangladesh. Also, virology has come out and they are doing many tests in Bangladesh. And most of their tests are being PCR based and antibody based. All together, that pathology is very important, and it is the bridge between the physicians and the clinic. When I worked in Saudi Arabia, I saw they do the treatment, evidence-based treatment. Evidence-based treatment without the pathological report and correct diagnosis, they cannot give the treatment. And without that, if any physician give treatment and there is wrong diagnosis and wrong treatment, he is doing the punishable act and he is punished. So they always behind the pathologist. They always concerned with the pathologist, with the microbiologist, with the biochemist, and with the virologist to get the correct diagnosis. Until and until you don't pick the report, they will not give the treatment. As because these bridges should be developed between the physicians and pathologists. And we should make them understand what is the importance of pathology. But our physicians, actually our failure also, it is also our failure that we do not teach our students what is the importance of pathology. Pathology is very important thing. Pathology not for the diagnosis, pathology for the prognosis, pathology for the therapeutic, for the treatment purpose also. So this is very important, and I think this is a very important topic. And Mahbub has well explained, especially the pathology part, the histopathological part. Thank you very much, Mahbub. It was very nicely presented. Thank you very much. Thank you.